Welcome to the Informed Pregnancy and Parenting Podcast. I'm your host, Dr. Elliot Berlin, and I'm joined by today's co-host, Angelica Ortiz. Angelica has an undergraduate degree in neuroscience and is currently completing her Doctor of Chiropractic degree with a focus on prenatal, pediatric, and family care. Welcome back.
Thank you. I'm happy to be here.
We have two special guests in the studio today. First is Dr. Allison Hill. Dr. Hill has been a board-certified obstetrician gynecologist since 2000 and is based in the Los Angeles area. She's co-author of the 2011 book, The Mommy Doc's Ultimate Guide to Pregnancy and Birth. She brought pregnancy and childbirth into our homes with the Discovery Health Channel TV series Deliver Me, and just recently released a brand new and quite fascinating book called Your Pregnancy, Your Way. Everything you need to know about natural pregnancy and childbirth. Welcome to the podcast.
Thank you for having me.
All right. Before we go too much further, our other guest today is Megan Bonneau. She's currently about 25 weeks pregnant with her first baby and is having a tough time deciding where she'd like to labor and deliver. She's considered a typical hospital birth with an obstetrician. She's looked into the idea of home birth with a midwife. Like many other soon-to-be parents, she's exploring the plethora of options and is looking for guidance and clarity on some of these choices. Welcome to the podcast to you and your tiny little nugget.
Thank you for having me.
You know, it was kind of like meant to be today because I was reading Dr. Hill's book. And we were setting up this podcast, and I was thinking about the audience. Who is the audience here? It's people who are thinking about getting pregnant, who are trying to explore the options, and there are so many choices. And it's really hard to find good information, and pros and cons from sort of non-biased sources is even harder. And you were just today in the office saying, oh, my God, what do I do? And I was like, well, we're recording this podcast. You should really listen to it tonight. And then I almost like jumped up. I'm like, you should come be on the podcast tonight. And so here we are.
I'm here.
Yeah, you're here. Thank you so much for coming.
Thanks for having me.
We've been planning this forever.
Yeah.
So, Dr. Hill, let's go back a little bit. I met you when we just started randomly having clients in common.
Yeah, I've been practicing out of Good Samaritan, downtown LA, since about 1999. And over the years, I had a number of patients that needed chiropractic treatments during their pregnancy. And I think it was kind of, we just had mutual patients over the years that always would come back raving about your office.
Oh.
And then we finally met at some point. Doing some prenatal classes and things like that.
Yes. Yeah. And then, it's the same. You were part of a group practice. Our patients would say really nice things about you. And so I think one day we just took our whole team and came over with lunch. And we said, we have to meet these doctors.
Yeah.
And it was great. I got to meet you, and you had this really fresh, unique energy. And then we had kind of several years back and forth where we saw people together. One of our clients was on your TV show.
Yeah, a number of them I think were over the years.
Well, one sticks out in particular because she had so much big energy. And like her thing was she was trying to do this natural childbirth at the hospital, and it was like, can Trish do this or not?
Right.
She had all the support and encouragement from you, and it was her second, right?
It was her second,
and her first one was not fun.
Exactly. She had a really, really long labor the first time around. So that was her big fear about trying a natural birth, was like, could she possibly hang in there for 2 or 3 days like she did the first time?
Right.
But I think with, she hadn't done any preparation with the first one. And so I think a lot of her preparation, and obviously just the fact too that it was the second, she kind of sailed through it. It was really amazing.
Yeah. And it's all captured on is that still viewable somewhere?
It's still viewable on YouTube.
Oh, on YouTube.
Yeah.
Okay,
and
great.
she's now the director of Pitch Perfect 3.
No, I didn't know that.
Yeah.
Oh, wow.
Cool. Yeah. Isn't
That's
that crazy?
amazing.
Yeah.
Yeah.
How quirky she is, and her
Oh, incredible.
The
energy out of her
amazing,
is amazing.
Her imagination is amazing. So she's directing Pitch Perfect 3, which comes out, I think, in November.
That's perfect.
We'll plug that on here.
There you go.
Yeah.
Pitch Perfect 3, don't miss
We're
it.
so proud of Trish. Like, she made it as a female director in Hollywood.
Oh, it's incredible. The stuff she was doing even back then was so unique and cool. I can't help but notice your book. I read through it, but the title struck me right away. Your Pregnancy, Your Way, which seems like that's how it should be, not just at Burger King, but even with childbirth. Let's plug them. But then it says everything you need to know about your natural pregnancy and childbirth, right?
Yeah.
it struck me right away. I'm like, people don't usually think about the obstetrician, medical doctor, surgeon when they're thinking about natural pregnancy and childbirth. So
Not at all. Not at all.
back me up and tell me how this came to be.
I think after having delivered literally thousands of babies and kind of watching my own evolution as an obstetrician, this book just made a lot of sense to me. When I first came out of my residency and I was practicing, as a brand new doctor, I was sort of in that mindset of I have to follow all the rules that I was taught for the last 4 years. And the longer, though, you practice, the more you see that there's a lot more wiggle room out there. And unfortunately, I think a lot of OBGYNs stay in that box. They're kind of afraid to look outside of, what actually might be better for the patient. And so over the years, as I practiced for, I ended up delivering babies for about 19 years. Definitely the way I practiced evolved. And I found that, the more flexibility I could give to my patients, the much better experience they had with still having a really great, safe outcome. And so I finally decided, I need to put this down on paper because most of the OBs aren't willing to go there. Mm-hmm. And it really leaves patients feeling that there's no other option, that they have to do it the way that the obstetrician is recommending and that anything else would be completely unsafe.
Right.
And when you actually look at the research and the studies on many of the technologies and many of the interventions that we use, there actually isn't a lot to support them. Mm-hmm. And this, of course, I'm talking about low-risk pregnancies.
Exactly.
I mean, high-risk pregnancies are a totally different ballgame, and you do have to follow the book on those.
So that's where it's sort of like who's low risk and who's high risk. I think we'll get to that in a minute, but it's the model of obstetrics seems to be set up for more high-risk situations.
That's all it's supposed to be for.
Right.
But unfortunately, it got extrapolated to all pregnancies. And I don't think it was really ever supposed to be that way. I mean, it really was supposed to be life-saving interventions for very severe conditions. But for a variety of reasons, all of that became the norm.
So I say this all the time. There's this push and push back, right? We have 1 in 3 babies roughly ends up in a cesarean and everything that leads up to that. And because of that, there's like this big pushback from the natural birth community to not do any interventions anytime. And then people just end up not trusting any of the practitioners and ending up in this very fearful situation that if I do this route, I have this concern. If I do that route, I have the other concern. So there's no safe route, which I almost think is where Megan might be ended up today. And I want to talk to you about that, Megan, but I would say that cesarean, all these interventions should be like the most amazing thing ever, right? It should be like 100 years ago, we didn't have a way to get this baby out safely. How incredible is it to live today? And we have this really safe, quick, and fairly easy way to get a baby out of you. But because it's so overused, a lot of these inventions, because a lot of these innovations are so overused, they become sometimes, I think, more harmful than good.
Exactly. And it's tough to find that balance. But there's a variety of things that are done routinely in labor between, obviously, some people ending up with a cesarean, but also inducing labor, having continuous fetal monitoring throughout labor, having an IV during labor, being in bed during labor, not being able to eat during labor. There's so many just little subtle things. And unfortunately, even just something simple as having an IV in labor can lead to a whole cascade of interventions that may end up with a cesarean. And it seems like that's such a simple thing. And I think as doctors, we often look at it as, well, it's no big deal. Getting an IV is no big deal. But you forget that once somebody has an IV, now it's going to be really hard for them to move around. And when they can't move around, they can't deal with their pain. And when they can't deal with their pain, they may end up getting an epidural. And when they end up getting an epidural, their blood pressure might drop. And then the baby's heart rate goes down. And then they then they have a cesarean. And it's like, it's the simplest thing that becomes the biggest thing.
So that's interesting because we were talking about that earlier today, right? I have no doubt in my mind, if we can jump into sort of home birth versus hospital birth for a low-risk pregnancy, I have no doubt in my mind that there are home births that would have ended up much better at the hospital.
Yes.
and that there are hospital births that would have ended up much better at home.
Yes.
So the question is, how do you juggle those two things? What are your thoughts on home birth? And
I think the decision to do a home birth has to, of course, be done very realistically in the sense of each mom really does have to look at her risk factors. I think that, the studies have shown, especially in countries where they do more home births even than here in the United States, like in the Netherlands and things like that. In the Netherlands, they have a very strict set of criteria for who can have their baby at home. Your baby, you have to be like between 37 to 42 weeks. You can't have passed meconium. Your baby has to be in the head down position. You can't be having twins. So there's certain things that they just draw the line.
yeah,
And again, it's not to say that some of those things couldn't be fudged a little
Yeah.
bit as well. But I think that, and you can't have any serious medical problems. The baby can't have any anomalies or malformations and things like that. So
as a general set of guidelines, it just seems really smart.
that basically throws you into the low risk category.
Right.
And I think the thing about, like in the Netherlands model, their midwives are very rigorously trained, all to a certain standard that is across the country. It's the same no matter what community you're in.
That's really interesting because we have so many.
We have so many
types
different
of
paths
midwives
to becoming a midwife.
Right.
And the other thing
That's confusing too, I think.
It's
even
really
like
confusing.
looking down that road of like,
Right.
wait a minute, there's like 5 different.
CPM, LM,
Yeah.
and they're actually overseen by different boards depending on which type of certification.
And it's in some states it's illegal. Like there is no it's illegal to have your baby at home. So
yeah,
midwives
there's
that
still
are
states where you can't
like
do it
almost
at home.
half of the states it's
Wow.
illegal.
Oh, wow.
And so you have to now you're kind of working with somebody who obviously doesn't
Practicing
have like
under
kind
the
of
table,
practicing on
kind
the
of,
fly.
yeah.
Right, it's underground.
Yeah.
you know,
And unfortunately
where
what
people
happens
drive 2 states over sometimes to
Yeah.
have a baby outside the hospital.
Wow.
But the other thing that I think really helps in the Netherlands is they also have a system in place where the midwife is already paired with a doctor, and the patient also knows that physician, so that if there is a transfer that's needed to be made, it's a seamless thing. It's not like, where am I going to take this person, my patient in labor who's having complications. It's already set up where they're going to go, how they're going to get there. And they have a really great success rate there.
That's all part of what makes home birth safe.
Yeah.
But Megan, you're stuck here in
I'm in
Southern
the U.S.
California.
I won't be
And,
traveling to the Netherlands.
Yeah.
Maybe I will after this podcast, but I don't know.
But your original plan was, have a baby at a hospital.
Yeah, I didn't really consider anything else. I've had friends that have done mainly hospital births. I have a friend who's done a home birth as well, and her baby boy was, it was a successful birth at home, and she said the most amazing things about it. But I didn't really consider it for myself, even as an option, until a few weeks ago when I toured hospital. And beautiful hospital and staff seemed lovely, but it was a very visceral reaction of walking into the hospital, and I just froze. And my husband was with me, and he thought I was mad at him, and I wasn't mad at him, but I couldn't really identify what was going on for me. And turns out, after a little kind of reflecting, that I have had some negative memories in the hospital from way back when, and pretty traumatic. And so I thought maybe I should consider other options. So I saw Dr. Berlin and was on your table, and we were talking about, I was telling you about the experience. And at that point, a number of things kind of shifted for me. I hadn't considered a doula before, but after that, and feeling how my body just reacted without me even mentally being able to figure out what was going on, I was like, okay, I need a doula. Okay, that's clear for me. And that was really reassuring of, okay, I think that's going to really help aid the process. But I started getting pretty freaked out about this whole, what else? Because before I went to the hospital, I was feeling actually really empowered, really enjoying my pregnancy, and, having a bump and getting smiles from random strangers on the street, and just really embracing this journey. So
That
then
sounds so nice.
Yeah.
You make it sound so
I
nice. I have a bump and I get like random, stares of dismay for bad choices. So
And then you walk into the hospital and you see the environment and you're terrified.
Yeah, and then I'm like, okay, wait a minute, maybe I don't want this bump. Like
Boy.
But how do I deal with this fear? And
And fear is such a, paralyzer, of course. I mean,
Yeah.
it totally slows down labor, and it's again, I mean, as physicians, we don't think about it a lot, but the patient's mindset makes such a difference in.
and I'm a therapist too, so
in, like, how they
I'm
can get through
already
this. Yeah.
wired a little sensitively,
Yeah.
to put it mildly, but and then I've been reading Ina May's book about rigidity, and it was like the paragraph of like, tense. If you're tense, you're not going to be open to birth.
it's so funny because when you talk about the IV, even just the IV, in addition to the physical limitations on mobility, just putting that like needle in someone's arm doesn't instill safety and confidence. It's fear. Like that goes. Like we think you're gonna die, but if we have this emergency shunt in there, we might be able to save you at the
Right,
last
exactly.
second. You don't like.
You don't need it right now, but in case something goes sideways,
Right,
you're
we're
all set. Yeah,
expecting the worst. And so just from a autonomic nervous system, it doesn't make you feel relaxed and parasympathetic. It just makes you on edge, and all your blood flow comes away from your core into your arms and legs. You just want to run and fight. And when Megan was on the table, that's like what she was describing. Like, I felt great, and I went into the hospital, and I just felt my sympathetic nervous system freak out.
And I'm not sick. Like, I'm having a baby, and objectively I know that, but part of me would love to. I mean, I'm a go-getter. I like a challenge. I'm driven, and, usually when a challenge is put in front of me, I'm like, all right, let's figure this out. And that's kind of where I've been. I'm kind of in this limbo position right now of like, do I want to conquer my fear, my old fears, and new fear of just, this new transition of being in a hospital and figuring that out? Because I think it could be a really cathartic experience with a supportive team around me. But then also speaking to a midwife and hearing about how calm and peaceful, and I can walk around and I can be in a tub and eat and,
wear your own clothes.
Wear my
not
own
be under a bright
clothes.
light.
And that's, so how do I make that decision?
Yeah. I mean, I think it's probably going to boil down to, your OB and kind of how flexible they are, and the midwife and how safe you feel with them.
Yeah.
I mean, one thing I always encourage my patients to actually ask the midwives, they're like if they're even interviewing midwives or something like that, is how often do you transfer to a hospital? And the truth is, I actually believe the higher number is better. Because what that means is that the midwife is really going to play it safe. They're only going to keep you at home if things are following the rules.
I didn't think about it like that.
You know what I mean?
Yeah.
And not that you want them jumping at the slightest little thing, but at the same time, if somebody, if somebody gets into a place where they're a little, they're not comfortable with your labor, and they say, you know what, let's go and get another opinion, like before it gets to the end of the line, then I think that's a good thing. I mean, that's just my opinion on it.
Sure. I mean, I go to home birth a lot with midwives as a doula or as a body worker, and they don't sit there waiting for that pink flag to turn red.
Exactly.
Right?
That's the sign of a really good midwife.
It doesn't go away. We're going to go to the hospital. No emergency, but it's like, hey, there's a little indicator light going on. We don't think we should stay home anymore and see where this goes, right? And we were talking about that
and
before.
So I think you just kind of have to mentally know, there is a chance I could end up with a hospital birth.
Right.
And you want to if those things
absolutely.
happen.
Exactly.
But the whole idea is home birth is only safe because we transport when you're no longer very low risk.
Right. And thankfully, I mean, most transports from home aren't emergent because most midwives are looking ahead, and they've done this a long time, and they can see the signs of like, when is it time to say no more.
Yeah.
I think, there are, as in any profession, there's probably going to be, there are some midwives who are so attached to the idea of you having your home birth that they may cut corners. And there are examples of that in the medical literature where clearly there were babies that shouldn't have been at home.
Yeah,
and
that's definitely not what I want.
Right. And those are the examples that doctors always bring up. They'll always say, well, this person, was at home and waited way too long. But the truth is, those are definitely the exceptions to the rule. I mean, the bottom line is the midwife wants you to have a great experience, but they want you to have a healthy baby at the end, no matter what, And I think just, learning your midwife's philosophy on transfers and things like that is probably an important place to start.
You said percentage of the higher the percentage. Is there any way of, which is maybe a big question to ask and put you on the spot.
Well, so I'll say the average, according to the medical literature, about 30% or so of first-time moms get transferred.
Okay.
And only about 5% of second-time moms.
Which anxiety's down.
Yeah.
Well, you know what it is? It's also, sometimes it's just because you're out of gas. I mean, that long birth,
exactly.
The first birth takes a while
so a lot
longer.
of times it's just people that just get to the end of their rope and they just are too tired. They happen to get this long labor, that kind of thing. Whereas always the second births are a lot faster.
Right.
And, that whole, once the path has been carved, that baby always comes out a lot easier the second time around.
Right.
I totally want to open up a second birth doula service.
Yeah,
that
would be the greatest job ever.
Right?
Carving the path.
Yeah. But that's what it is on national. That's the national average for transfers. And again, over 90% of those transfers are non-emergent.
Right.
They're either something the midwife is noticing, or it's on request of the patient.
Got it.
Who's I don't know what I was thinking.
Right.
Which I think everybody will think at some point in time during labor. One of my midwife's friends, in fact, said to me, she said, a lot of people say they don't think they can do it anymore. She goes, but I only take seriously the ones that get up and start putting on their clothes and going out to the car. Because a lot of people will say it in the heat of the moment.
Right.
But
I can't remember the last birth I was at where we didn't get to that you guys point. You guys, I don't know about this anymore. You guys. And
but until they actually get up and go put on their clothes and head out the door,
not serious.
They're not serious.
No, you guys means convince me that I should stay.
Yeah. Right.
I'm out of here. I'm leaving, and you can come if you want to. All right.
Great.
Is that helpful?
Yeah.
Okay.
That's really helpful.
I have a few. You mentioned some of the things that you feel high risk based on other countries. What are the benchmarks in your mind where it's hey, you should really be under the care of obstetrician during your
it's
birth?
Definitely obviously if you have a high blood pressure, if you have a medical condition before the pregnancy starts, you need to have an obstetrician on the team.
Okay.
If it's well controlled, for example, if you have diabetes, that might be something that, the midwife, if it's well controlled, that you can still stay with them. But if you have any big medical condition, you definitely need to be under the care of an OB. And then the other things would be things like, if your baby's breech, you need to have a consultation. You need to be talking with an OB on that one. If you're going into labor, obviously prematurely, those kind of things.
Before 37.
Before 37
in California,
weeks.
Anyway, it's before 37.
Yeah.
After 42, can't be with a midwife.
Right.
So, okay.
Are there specific types of breech that can't be done at home?
There aren't. I mean, I think though,
Well, you just jumped into breech at home, but it's let's just even talk about
a high risk.
Well, let's just even talk about breech at the hospital for a second. I mean, most obstetricians don't do breech deliveries anymore.
Not anymore. I mean, I hadn't done one I think I've only done 3 in private practice.
In 20 years?
In 20 years.
Wow.
Because people don't want them, or just because the training's not there?
Because of the training. Yeah, so 20 years ago, that was right when that term breech trial came out.
And you didn't get the training.
And everybody just flipped to just do a C-section. And that was the end of it.
Everybody just flipped.
Yeah, and there was just, and so the thing about it that's tough is that there are very few obstetricians who are adequately trained.
Yes.
And so when a patient would ask me to do one, I'm like, I haven't done this in years. I mean, I would feel personally really uncomfortable.
Sure, and that's not safe either.
Exactly.
You need to know what you're doing.
Exactly.
If you don't feel confident, then, when those risks of breech do happen, you're at a loss for how to save the day.
Right.
So,
I mean, I think the big issue right now with breech is trying to get them to turn earlier in the pregnancy.
That's me.
Yeah, exactly.
We're working on Angelica's my witness. We do like 4 a day.
Yeah, because one of the big
So
things for OBs is that we're trained to not even really bother with looking where the baby is at until 36, 37
Right,
weeks.
and then it's very late.
And then it gets a lot harder. Whereas obviously if we started addressing that issue earlier on, and we were always taught like, oh, well, if the baby's breech at 32 weeks, probably it's not going to be at term anyway. So why bother doing any other steps?
Right. I always beg OBs to check at 32 weeks,
Yeah.
just so you know. And
Right.
You can
Check with
start
the
to,
OB of whether you're breech or not.
Yeah, if the
Yeah.
baby's head down or not. Because at 32 weeks, almost 90% of babies are head down. And it's true, at birth, it's more like 96 or 97. So more than half of those babies will turn. But when we start working on it early, it's a little over 90% of the babies
Right.
that turn. So
And even
it's not a panicky moment at 32 weeks.
even
but
the
it's,
moms can start even doing
Better to
postures
know
at
earlier.
homes and
Yeah,
just
home
different things
exercises.
to encourage it as well. And I think that's where the training again of OBs has been, well, don't even bother looking because most of them are going to turn anyway. And then you get down to the last couple of weeks of pregnancy, and now the baby's getting bigger, and
It's so stressful.
and
There's no
stuck
time
in
to
there, and the
process all
mom's
the choices.
panicked. Yeah, and again the stress and
Yeah.
becoming rigid because she's totally freaked out that it's not going to turn, and so I mean I think that's one thing that could definitely change, and also encouraging more doctors to do external cephalic
It's
versions.
going the other way. I see the doctors giving up on the version
Giving
and just jumping right into cesarean.
Yeah.
And the misinformation is, people come out of that consultation feeling like the odds of the placenta being pulled off the wall or the
Are
baby
like-
just suffocating
as if
and
that's
dying
like such a common
is going to be
occurrence.
very likely, and the odds of success are almost none. But really,
Right.
it's the opposite. For most women,
Exactly.
the odds of success are somewhere around 40 or 50%.
Right.
And
And-
the odds of something going wrong are negligible.
Yeah, I saw a recent study that actually showed that only about 35% of breech moms are even offered a
An
version.
external version. It's
You
going
know?
Wow.
it's going
Yeah.
down.
And
it's-
it really is unfortunate because that's going to be another skill that people are going to lose,
Exactly.
that obstetricians are going to lose. And it does have a great success rate. But I think, going back to all the other things that also influence an OBGYN, the truth is that for an OB, it's a lot easier to say, I'm going to deliver your baby by C-section at 10 o'clock on Tuesday, for a variety of reasons.
Yeah. I mean, if you're just a human being saying, what's the best for me, taking out all the other factors, if I'm an OB, a C-section is going to be great every time.
Always.
The only downside to it is that people don't like them.
Yeah.
From my OB perspective.
Right.
For the woman, there's other downsides.
And for the baby, too.
And for the baby, there's other downsides. But as an OB, just knowing how predictable your schedule can be. I mean, we were
convenient.
talking earlier
Yeah.
how you have how you raise children, right?
Yeah, doing that.
As an obstetrician, how do you do it? I mean, and so, some of my OB friends have like 4 or 5 kids, and they're just I don't know how you do it.
Yeah.
I have 4 kids and I run to birth all the time, but I have a wife.
Yeah.
So how do you do it without a wife? You
Yeah.
need a wife. Everybody needs a wife.
Yeah, it is. And unfortunately, that influences us more than I think anybody wants to admit.
Yeah,
I
because
mean,
you're human. I mean,
yeah,
it makes sense that it
want to
would.
have you want to have a life.
And I
You
don't mean
want
it from
to.
a negative perspective. I also feel like many of my OB friends don't really see the downside for the mom or the baby.
They don't.
And it's almost like this is the better way
Yeah.
to have the baby.
It's
we
a
were-
solution.
It's become routine, though. I mean, it makes sense.
Well, it's just like
Right.
quick and easy and controllable and predictable for the most part.
Yeah.
Right?
I mean, we were
So-
always taught the phrase, you can never be faulted for doing a cesarean. You can only be faulted for not doing one.
from a liability perspective.
From a liability
Right.
perspective.
You actually have less liability
Wow.
if
Yeah.
you do a cesarean.
I
Because
mean, that's from when,
The odds are in
Yeah.
that favor then.
in
yeah.
malpractice,
I mean, that was something.
they always look at, did you do everything you could have done to help this baby, right? Or
Right.
to help this mother. So interventions are rewarded when it comes to defending yourself against
Right.
malpractice, and standing with your hands in your pocket is punished.
Yeah. Yeah, and it's unfortunately though also malpractice suits are very common in obstetrics.
Right.
And so it's not to say that it's not a real fear. Getting sued is terrible.
Oh, it's the
and
worst.
every OB gets sued on average 3 times during their career, and
crazy.
it's like
As if you didn't have a stressful enough
it's
already.
heart-wrenching. I mean, it's really tough to go through that. And so there is a real, impact that you're always thinking, there's a real cause and effect that when you think about your malpractice and then how it changes the way you practice. But it does. It's unfortunate.
Sure.
I mean, and until obstetricians don't get sued anymore for not performing a cesarean, they're just going to keep performing more cesareans.
Or get paid a lot more for doing a vaginal birth.
Yeah, exactly.
One or the other.
Yeah.
Oh, that would...
What about VBAC?
I'm a huge fan of VBAC too. I'm a little leery about VBAC at home. That's
Okay.
my only, and I know people do it, and I totally get why they do it.
I love how excited you were, but I'm like a huge fan of VBAC. You almost sounded like have a cesarean so you can have a VBAC.
But I think there's a lot of patients who are great candidates for VBAC, and again, kind of get, they get sort of the obstetrician's stand on it, which scares them to death.
Skewed informed consent.
Yeah.
These are all the terrible things that can happen.
Yeah, and so I think not as many people.
From a vaginal birth, and this is the tiny one-sheeted paper of bad things that can happen from a cesarean birth.
Yeah, so it's I think their informed consent is really skewed. I am a little like the home thing. I do debate about because, there are uterine ruptures that occur quickly, and you have about 30 minutes to get that baby out of your body.
Yeah.
And if you're at home in your bed and you've got any sort of, you have to get dressed, you have to go get in your car, you have to drive there, you have to get checked into the hospital. Like, there are some bad things that can happen. Now, if you live really close to a hospital, and if your midwife is also very skilled in and has done a lot of VBACs and can really see the early signs of a possible rupture and says, you know what, let's go. Like, let's not, then I think it's okay.
So that's one of the arguments I hear for out-of-hospital VBAC, which is, number one, if you feel a lot more relaxed and a lot safer, it's bound to go better. Labor will go faster and smoother, less work on the uterus, wear and tear on the uterus, are less likely to rupture, but also the midwives are just so in tune from those hour-long visits all pregnancy long, and from knowing you holistically, knowing your mind and your body, and just really being able to read your energy and sitting next to you, whereas, the OB is not there usually, although you seem to spend a lot of time at birth with your clients. The average is come for pushing and leave.
Exactly. But yeah, it is, there is definitely an art to knowing when somebody's rupturing their uterus, and it took me many years to develop that, and so definitely if somebody's going to do one at home with a midwife, you really want to ask them, how many of these have you done? What is your comfort level with this? And to be really realistic about whether they are skilled
with the
enough.
questions.
Yeah. I mean, and hopefully the person is upfront with you, like, I haven't done that many yet. That's probably not the person, unless there's going to be another person there with you as well. And it's not common for a rupture to, go from 0 to 60 in a minute.
It's slowly
it
evolving.
Usually is more of a slowly evolving
The word
thing.
rupture just sounds like a bomb goes
Oh,
off.
it sounds terrible. I
Scar
know.
separation sounds a little
Yeah,
bit-
exactly.
Yeah.
But yeah, if they are really trained in the subtle signs, and can make the decision to go at a good point, then I think it's okay.
And if you live close, like you
And
said.
if you live close.
Because, I guess one of the arguments why VBAC went down for a while is hospitals that don't have an OB or an anesthesiologist in the facility 24/7, they wonder how long it'll take them to put together that team.
Right.
And like you said, 30 minutes seems to be about the tipping point. So
if
you only live 5 minutes from a hospital that has 24/7 operating rooms going.
Right. I think it's probably more of an issue, obviously, for women who live in more rural areas, where the hospital is quite far away. And
they only do 100 births, a year, or even 300 births a year. There's nobody waiting around for you.
Exactly.
And there's a lot of hospitals like that.
There really are. There really are. And again, I think the main thing is trying to prevent that first C-section
Would be
from the
nice.
first place.
Yeah.
So not so many people even have to make this decision.
That's why breech is so critical. We have 4%
Right.
breech rate, then 4 out of 100 babies are born by cesarean.
Right.
You're off to a bad start.
Yeah, exactly.
Let's talk about common things that happen during labor, interventions. Angelica's studying to be a doula,
Yeah. In May.
in addition to everything else. And these are doula questions that come up all the time, not just during the interview or during getting ready for birth, but literally at the birth, these questions come up. And if they haven't been well researched, we don't know what the pros and cons are of the different choices. So you mentioned the IV.
Yeah.
What's the benefit of having an IV, and how bad would it be if you didn't have one? It seems like you'd just start one if you need one.
Right. Yeah. It really is that whole in case something tragic happens so urgently, but it's the odds of that are so small, and really the medical research does not support its use. It doesn't benefit mom or baby. So
For my own births with my wife, I always felt like, why don't we just see if we need one at some point?
Right.
If there's if you feel like she's getting dehydrated, or you feel like she might need an interventive drug that's given by intravenous delivery, why don't we talk about it then?
Right, exactly.
But it's common practice right away,
It's
right?
pretty standard. It's about 80% of laboring moms have an IV.
And the hospitals
in
get
the
really
hospital.
uncomfortable if
How
you
is
don't
that
do it.
determined? The 80%. What
I
makes
think it's
them-
different. I think there are different hospitals and different physicians who are comfortable with different protocols. Like I know at my hospital, it used to be that everybody had to have an IV, and then that was a hospital protocol, and then they made it at the doctor's discretion. So there's going to be certain doctors that are comfortable with it, but again, for most doctors, they were always trained with it, and the doctor doesn't feel
The comfort
comfortable.
zone, yeah.
It's just like things that are set in stone. But there's no medical evidence that it benefits the mom or the baby, especially in the case where the mom can just drink water or drink. She can just say
They're
when she's
constantly
thirsty
drinking
and just
water,
drink.
drinking coconut
Yeah.
I'm already
water.
scheming if I deliver at the hospital how to get food and
Yeah.
stuff
Well, that's
to
another thing.
drink.
What about
Well,
not eating?
and the food is another
Uber
one.
Eats, right? Yeah.
Right?
and,
It's like contraband.
DoorDash. Yeah.
Yeah,
whatever it
exactly.
is. Yeah.
The food one goes back to this journal article in a anesthesia journal from the 1940s
Oh, wow.
that suggested that women should not eat during labor. That's where that all started, in that if a woman had a really full stomach, she may aspirate or she may throw up and then breathe the food in and all this kind of stuff.
During labor or
During
surgery?
labor. During labor even.
Or just regular labor?
During
Okay.
just regular labor. And so that became the norm, that nobody could eat. And
But people do throw up commonly during labor.
They do, but they're not,
But they're conscious.
They're conscious,
So
exactly.
they're not going to choke and die.
Exactly. And so
I would have thought during, if we were concerned about going into surgery, maybe once, if they have general anesthesia, they're not conscious, then they throw up and the food comes down.
except for the fact that then they have a tube in their mouth.
Right.
Do you know what I mean? So they're not in
So that's why I've had a hard time picturing this.
Yeah.
Why would we do surgery if you're a low risk healthy person? If we did surgery, we wouldn't do general anesthesia.
Right.
We'd give you a local anesthetic. And if we had to give you general anesthesia, we'd still intubate you.
Exactly.
So there's a tube in your throat that doesn't let anything in except for air.
Right.
So why can't you eat?
Right. So
We're on the same page.
it has been just the way things are for years and years. And then interestingly, just in 2015, some other anesthesiologist presented a paper at their national anesthesia meeting that actually encouraged women to eat during labor because of the fact that they would not develop ketosis, they would keep their blood sugar good.
Yeah,
And
in the
that would
zone.
actually help them progress during labor.
Of course.
Because
Right.
it's stamina, right?
Right.
It's like a long
It's just like you're doing a marathon.
marathon, yeah.
But basically, this paper that they presented kind of went against everything that people had thought. And the truth is, there is no medical evidence that eating during labor, again, in a low-risk patient,
Increases risk.
is any issues. It really, I think the only patients that maybe couldn't eat would be if a woman has a seizure disorder or, some very critical, really high blood pressure, some very critical disease where they might have a seizure or something like that. But other than that, it's really, there's no evidence that abstaining from food helps.
Right. Is
That makes
ketosis common in pregnancy? Do you see it often?
No, just more during labor.
During labor.
Yeah, just because again, people just haven't. They're burning a lot of sugar and not taking anything in.
Someone undergo like over 20 hours. I mean, imagine not eating, how hangry you would be.
Yeah. And I will say, I mean, most patients during labor, during active labor, are not like, hey, I want a turkey sandwich. I mean, that's sort of the last thing on your mind. It really is during the latent phase when you're just kind of contracting on and off, and during that initial time, which is usually the long part.
Right.
You know, once you get to the active part, it's pretty quick. But that latent phase is really when keeping your hydration up and eating is really beneficial for you and the baby.
Okay, good.
What are your thoughts on group E strep?
Oh, God, this is another one.
I got a whole list. And
I know.
These are conversations that come up. Angelica is shadowing me now, so she's in the room with me a lot. These are questions people have. I mean, they're legitimate questions. What is group E? What is group E strep? And how do we test for it? Why do we test for it? And how do we treat it? And is that treatment right for everybody?
Yeah, so group E strep is a bacteria that about 30% of women carry in their vagina for an unknown reason. We don't know why. Some people are carriers and other people aren't, but it does affect about 30% of women. What we know about it is that if a baby is exposed to group E strep through the birth canal during delivery, there is the chance that the baby could develop a group E strep infection, which can range anything from just a little rapid breathing all the way to meningitis, pneumonia, death, those kind of things. So it can be
really serious.
A really serious infection. In most babies that have had group E strep, it's not that serious, but there are some cases where it does get very, very serious. But the chance of, if you're a group E strep carrier, the chance that your baby would die of a group E strep infection is well less than 1%. So it's not like this is some really high risk. However, it is one of the more common causes of neonatal death. And so people take it seriously.
Sure.
And how do you find out if you're a carrier?
So the recommendation right now is that all pregnant women are screened for group B strep at about 37 weeks of pregnancy. Group E strep is a little finicky. Like sometimes somebody will test positive for it, and then they check again in a week, and then it's negative, and then they check again another week, and it's positive again. It kind of like the levels of it can go up and down. Basically, though, the way that we look at it is that if you've ever tested positive, you're positive, and you shouldn't ignore that.
Meaning even on a totally different pregnancy?
Even on a different pregnancy.
So if on your first baby positive, then...
You're technically considered always positive.
No kidding.
So the problem with it is that the most effective treatment to prevent the baby from getting an infection are IV antibiotics.
During labor.
During labor. They have found that oral antibiotics, taking them as a pill, doesn't penetrate enough into the uterus to help the baby in any way. So unfortunately, they have to be given as an IV. So now here we are back again to now you have to have an IV.
Not just an IV, but you have to have IV antibiotics.
And antibiotics,
as if there's no downside to killing all of the good bacteria.
Right, exactly.
With the bad bacteria.
Exactly.
And I don't know how well that's been researched.
That has not been researched at all.
Right. So, I mean, there is some chance that we are harming babies.
Yes.
Who would have been okay.
Right.
With this treatment.
Right.
And the only reason I bring that up is because I know it varies. Different hospitals and different obstetricians have different protocols. I even know OBs that will test you at 37 weeks, and if you're positive, give you some home remedies and test you again at 39 weeks. And if you're negative, they won't recommend the antibiotic, or they'll let you not have the antibiotics in labor. And then all the way back to if you test once positive,
you're always positive. Yeah. So the ACOG guidelines are that if you've ever tested positive, you're positive, and you need to be treated in labor. But there is, again, different people do it different ways.
And that's just a recommendation. It's not a law.
Exactly. And I think, unfortunately, they haven't found a great way to prevent it other than the antibiotics so far. They've done some research on all sorts of different things, garlic, probiotics, using tea tree oil, chlorhexidine when the baby is born to wash the baby with.
That's another question. Why don't they just treat the baby after birth?
Yeah.
Right, because the infection can take off.
quickly.
It can. And, it's one of those things in my, again, 20 years of practice, I've had one patient whose baby died of group B strep meningitis, and she tested negative at 37 weeks. So you can see it's not perfect either way.
I mean,
so
that
just because
starts to make you think, well, whether you test positive or negative,
just
we'll
do
just
it.
give everybody antibiotics.
Now,
because nobody wants any baby to be harmed.
Exactly.
But it's just like that kind of thinking then gets you into the trouble.
Right.
Where we're harming babies with antibiotics.
Right.
That would have been okay.
Yeah. That's a really tough one. I mean, the one thing about the antibiotics is that they are usually given just every 6 hours. Mm-hmm. Licensed midwives can't even give them at home.
Yeah, sure.
So you can have an IV where you run the antibiotic in. It takes about 15 minutes to run it in. And then they can just disconnect the IV and put like a little cap on the end of it. So then 6 hours later, you can get your next dose. So it doesn't necessarily mean you have to be tethered to the pole.
It's incentive to get that baby out.
Yeah. That's right.
Oh, it's 5 hours and 20 minutes.
Come on.
No, C-section.
Yeah, exactly.
So obviously at home, just shifting gears a little bit, we don't have constant monitoring at home of the baby. And at the hospital, constant monitoring, sometimes I see they want it for everybody all the time. Sometimes only if there's, decelerations in the pattern or if there's, let's say, a VBAC. What are your thoughts on fetal monitoring?
The continuous monitoring is the bane of our existence. I mean, I think that is why our C-section rates are so high.
Really?
100%.
Tell me more about that.
Yeah. So continuous fetal monitoring began in the late 1960s. And basically the idea was that if we could monitor the baby's heart rate during labor, we could detect times where the baby was under stress and deliver the baby early so that the baby would not be brain damaged. I mean, that's kind of the gist of it. Basically, though, it has been around since the late 1960s. It hasn't changed the rate of brain damage at all. It hasn't improved the rate of cerebral palsy. The only thing that has really happened is the C-section rate went up like 6 times.
Because every time you see a deceleration?
The problem is that it's not black and white. It's very much up to interpretation, and you never exactly know how much stress is too much. There's no test for that. And so, and basically every study since that, those initial ones in the 1960s have shown that continuous fetal monitoring in the low-risk mom does not improve outcomes.
But it does increase cesarean.
But it increases the cesarean rate. Yeah. And so,
Megan's eyeballs are coming
eye
up.
rolled. No
so
one can see it,
what we think is helpful though is intermittent monitoring, which kind of varies from facility to facility what they consider intermittent.
Or even at home.
Yeah, or even at home, where they'll listen to the baby's heart rate after a few contractions every hour and see if it looks normal. But basically the studies have shown that by us jumping on every little permutation, we're not improving the outcome. We're just increasing the C-section rate.
So would that be a question to ask the hospital if they support intermittent monitoring, or
it's
the
probably
OB?
more your OB.
Okay.
It's usually up to the discretion of the doctor in most facilities. But there are just...
I think that's true. But there are a handful of facilities that don't leave that up to the doctor.
Yeah.
So, but you start with your doctor because they'll know either the hospital policy or their own policy.
Right, exactly.
But that's often one of the reasons people say you can't have a baby at home because they don't have that monitor.
Right, exactly.
But it's almost like one of the reasons you want to have a baby at home.
Exactly. And then the other thing with the monitor, of course, is that the continuous monitor is that you're tethered to it. Now you're back in, again, with immobility, and things like that, just like having an IV. It has cords that you attach from the monitor to you that are about 4 or 5 feet long, and you can't go any further than that.
So there's no way you can, leave the room with...
Well, the hospital that you're thinking about, new technology has solutions for that. The hospital you were talking about has telemetry where...
Some of them are getting the wireless.
You can do it wirelessly.
Like basically it's like Bluetoothed. But one of the problems with it is that it's really common that as you're walking or doing something like that, the baby moves and now you're off of the monitor and then everybody freaks out.
They come tackle you wherever you are in the halls.
Yeah.
It's true. That technology has to get better, and I think it is improving. I've seen it go through various stages of development.
I'm sure it will
already,
get there.
But I don't understand why it's not just a sticker that goes here and a sticker that goes there. Like we can make everything so nano today.
Yeah. Wireless.
These big clunky things that you have to strap onto your body like 1940. Yes.
Yeah.
I think we'll get there, but right now, and I think
and
the
not
last
that many.
I saw,
I don't think that many hospitals have it.
A lot of hospitals don't have it, and when they have it, they don't always work well. It's technology, so you have tech problems. But I did see a really cool one that's down. It's not quite a sticker, but it's pretty small, and it's waterproof, so you can even get in the tub and the shower with it. So they're trying. They're working towards getting there. But
I'm sure that will get there.
The time being, it's still a tether, and it's also, I think one of the other problems with that constant monitoring is the printout. It prints out everything that happens the entire time you're in labor. And if I was an OB, I would just look at that printout and think that is evidence. You know?
Well, and I think a lot of OBs look at it as, this is my defense. Like, they think of this is my defense, so that they can see that as soon as anything got out of hand, I pulled the plug,
right.
And I did a C-section.
Right, or on the flip side, if I don't
run
into a cesarean, this is evidence that will be used against
exactly.
me. So it's either way, that kind of puts you out of your comfort zone.
Right.
And if the OB is thinking about the OB, which is human to do,
right.
you're going to look at that monitor frequently. And I mean, when I'm in a birth and someone's on the monitor, pretty much all the eyes are just staring at that monitor.
Watching the BP.
Right? It's like Lord of the Rings. Carry it across the screen and then back over here. Carry it across the screen again. I'm like, let's do something. Let's walk around. Let's move.
Yeah.
Let's have some coconut. Oh, you're not allowed to.
I think, though, unfortunately, and even within the American College of OBGYN, they are admitting the fact that continuous fetal monitoring became the norm without really being tested in terms of the long-term side effects to it. And even they realize it's not something that needs to be done in a low-risk pregnancy. I mean, you can if you want to, but it's not something that has to be.
Let's just talk about one or two. I'm going to give everybody one more question, okay? But I have so many. Like, we didn't talk, just by way of things we didn't talk about is rupturing water, epidurals, and other forms of pain medicine. We definitely have to have you back. Episiotomy, and even after the baby comes, delayed cord clamping, vitamin K, antibiotics in the eyes, eating the placenta.
I want to know all those answers.
Yes.
So
I am going to give you Dr. Hill's book.
I know.
So you're going to get the answers. Everybody else has to buy Dr. Hill's book, and it's well worth it. And it's on Amazon.
Yep, starting April 11th.
Yeah, but by the time this airs.
Yeah.
It's very
It's on Amazon.
It's on Amazon.
It's a great book. My last question for you, which might take a minute or two to answer, and you guys could think of yours, is induction.
Yeah. So induction is another obstetrician, kind of way to make our lifestyles better in many cases. Mm-hmm. There are basically 2 conditions total that have ever been proven where an induction benefits the mom and or the baby. And those are preeclampsia.
Okay.
And being postdates after 43 weeks.
Okay. Now that you said that, let's talk about what is preeclampsia and why induction is helpful for it, and then we'll get back to the other one.
So preeclampsia is a maternal condition where the mother develops high blood pressure as a result of the pregnancy itself. So it's not a, before you were pregnant, I have high blood pressure, but this is something that results because of the pregnancy. To be honest, we don't know why this happens.
Are there other signs besides the high blood pressure?
The main things are high blood pressure, excessive swelling, and having protein in your urine. So that's why every time when you go to your OB's office, they collect a urine sample and they're looking for early signs of preeclampsia. Mm-hmm. There is no cure for preeclampsia other than delivering your baby. Once your baby is out, your blood pressure goes back to normal. In many, many moms who with preeclampsia, the blood pressure is slightly elevated. They might have a little bit of protein in the urine. It's not some crazy thing. There are other people who have really high blood pressure to the point where they can have a seizure, they can have a stroke. which basically almost happened to me, which was so great.
Oh, really?
So yeah, I'm like the poster child of preeclampsia.
Wait a second. Now we definitely have to have you back.
I know. I got severe preeclampsia and HELP syndrome at 29 weeks with my son.
Now we have to talk about HELP syndrome.
I know. So
All right. You're definitely coming back for part 2.
So, but basically the balance is that we try to keep the baby inside the mom as the incubator as long as possible. But if the mom's health becomes at risk, we have to deliver the baby. The baby has to come out because the mom is just going to get sicker and sicker. Yeah. And so, again, if it's close to full term, and the blood pressure is just a little bit high, sometimes it's okay to wait for the mom to go into labor. But if the mom is like how I was at 29 weeks and nowhere near being ready to deliver the baby, but like ready to have a stroke, then I had to be induced. Oh. So that is the one condition. That is one of the 2 conditions.
Is it recurring preeclampsia?
It often, if you had it with your first really early in the pregnancy, you'll often get it again in the second one, which I also did, but not until 36 weeks. So that was pretty good.
But if you get it late, then it may or may not
usually
come
if you
back?
get it late, it's most common in first-time moms. So especially if you get it really close to the end, most likely it's not going to be an issue the second time around.
And the second one you said is past 43 weeks.
Past 43 weeks.
I always look at the birth window as 38 to 42 as like the bell
that
curve.
just blew my mind when you said 43 weeks.
But they do basically what ACOG has shown is that between 42 to 43 weeks, if the baby is looking good, if some of our non-stress testing and things, which we'll have to discuss at another visit too, are normal, technically you can wait until 43.
Okay.
But they basically, though, what they show is that as you start to go past 43 weeks, there starts to be more complications for the baby.
Past 43.
Past 43.
What I don't love is how it becomes just like a standard rule. When
well,
you hit
and it
41,
almost becomes now past your due date. I mean,
well, I see 40 now. Like, we don't let you go past your 40 or like, 3 days over.
Yeah, I mean,
very
people,
commonly,
as soon as that date hits, they are like signing you up.
Right. It's like the use by date, but really it's just the sell by date.
It is. And it's there is plenty of time. But again, I think a lot of doctors start to get uncomfortable. And the truth is, there's a lot of moms that start to get to the end of their rope. And they get a lot of pressure with people calling them.
But that's a different story if you want it.
Right, exactly.
Then if it's like my policy is 40 weeks and 5 days, and that's it.
Right.
How do you know? Like even the date is not that accurate.
Not at all. No, it's really inaccurate.
Like you talked about monitoring the baby, and is this baby healthy? Is this mom healthy? Can we go another few days or not? That seems like a much more level-headed approach.
And the bottom line is those last few days or weeks are really important for the baby getting in the right position for childbirth. And, trying to get somebody going in labor before that baby has settled in is like banging your head against the wall. So,
it feels like those last moments are like the airplane making those final wing flap maneuvers.
Yeah.
And if you just force it to land before that happens, it could really go not well.
It just doesn't go well. So, but basically though, those are the only 2 indications where it's actually been proven with multiple studies that it can benefit either mom or baby. All of the other ones, low amniotic fluid, that's a huge pet peeve of mine. People get induced for that.
No matter how low it goes? Or you're just saying like under 9?
No, it's basically the studies show that if low amniotic fluid is the only problem.
Everything else looks good.
Everything else looks good, meaning your blood pressure looks good, there's no signs of preeclampsia, your baby's growing well. If everything else looks good and it's only the low fluid, there's no benefit in inducing. But yet it's one of the most common reasons why.
I see low fluid, big baby, small baby, the placenta has calcification. And these come up a lot more often, by the way, around Thanksgiving and Christmas.
Of course. Basically all of the other litany of reasons that people give for inducing have not ever been proven to help.
I need to say this. I could never be an obstetrician. You guys have so many pressures on you from all sides, from liability insurance, from how much insurance will pay you, from jumping out in the, from the bottom of your heart. I'm sure you want to be there with your clients in labor whenever they want to labor, but how can you have a busy practice like that? I could never do it. So I'm not here to give obstetricians a hard time. I respect you very much. It's just hard to like be a person who's going to have a child. And if you just do what your OB tells you, you're definitely not getting the full spectrum of information. Right. So encourage people to talk to their obstetricians but also be an active part of the decision making.
Yeah,
definitely. And having your book is a really
I think a lot
resource.
of patients would be really surprised to know that we make decisions that aren't necessarily based on what's best for them.
Even the
and that's the bottom line.
That you're talking about.
Answer.
ACOG very honestly says a lot of our stuff is just based on consensus opinion, but not based on actual studies that prove that we're right.
Yeah.
So it's just like,
and I actually think a lot of women don't know that. They think that the decisions are being made for them.
I think so too. Yeah. I mean, that's definitely how we paint it.
Yeah. All right, you guys each get one question.
Go for it.
Okay. So I was at a seminar a few weeks ago, and I got to watch like a whole afternoon of birthing videos. And they would give a little in a synopsis of the birthing video, and all the epidural videos that I saw were insanely long. And not only that, but the babies, like when they, were born eventually, they were like not even like moving, like just like, like you can tell that they had been like on some type of medication. So I think my question to you is like, do you think that epidurals like slow down the process of labor?
They definitely slow down the second stage, the pushing, for sure, because the mom just doesn't have the same sensation, like the feedback. Overall, the studies show that the first part of labor tends to progress at relatively the same pace, but the second part is elongated for sure. I think the thing about epidurals is that they are great for the mom who hasn't prepared or just is not interested in pursuing something natural. I mean, the pain can really be overwhelming. Right. And there are definitely patients where they are so spun out that if they don't get some relief, they're definitely going to end up with a C-section. You know what I mean? Because they become rigid, and sometimes they get to this tipping point where it's so hard to talk them back off the ledge. And those moms, I think, have to do an epidural. Right. Also for like moms whose labor is induced, for, people that have to stay in bed, people that have the IV. I mean, it gets harder and harder to not use an epidural. And like 80% of people in the United States get one.
Right.
But it definitely slows down that second stage.
Definitely. Okay. Thank you.
That actually ties into kind of my question of despite where I end up delivering, whether at a hospital or at home, I guess at home it would be natural, unmedicated birth. But if I do end up delivering at the hospital, I want that as well. And I guess my question is, over the many babies you've delivered and the women who are able to do that, what are your suggestions, or what's your insight as to how you can do how I can do that?
I think probably the two most important things are, don't go to the hospital too soon. Mm-hmm. That's like a huge thing, because if you go to the hospital and you're 2 centimeters dilated, the odds are you're going to end up with an epidural.
Okay.
I always feel like in that case, it's like you showed up to lunch at 9:00 in the morning.
Yeah.
And the restaurant staff is not sure what to do with you.
Yeah.
It's like,
and then
why don't you have some drinks or some appetizers? Let's break your water.
Then they start doing things to you.
Yeah.
They really do. I think trying to stay and labor at home, even if you're planning to deliver in the hospital, is a really important thing. And then staying mobile. You have to be mobile if you're going to do it without an epidural.
Okay.
And that then goes to
staying at home longer, right?
Staying at home longer, but also like then talking to your doctor about the fact that I don't want to get an IV right when I come in. Can I do intermittent monitoring? Kind of having those things set up ahead of time so that when you do get there, you might have a quick check of the baby, check your blood pressure, but then you can be up and walking, squatting, like be wherever you need to be.
Those big questions already answered.
So
I can go right into.
Because I think the movement is so important. Okay. Because you'll naturally. I mean, Elliot, you know this too. Like you'll naturally move your body in a way that helps your baby come out. You'll rock, you'll move back and forth, and it's like all of those movements are so important. And if you're just laying there on your back, like strapped to 3 things, your baby's just going to get sitting in there, and then your labor takes a really long time. Right. And so I think, those kind of things are probably those two are probably most important in my mind.
Okay. I love watching other species, other animals, mammals giving birth. There's so many videos on YouTube now where you can watch elephants give birth
elephant
and
one's so
zebras.
good.
The
I watched the
elephants are
elephant.
so cool.
It's
pretty cool.
And they're always upright and they do this kind of like
Yeah.
dance back and forth. I've never seen one laying on her back watching TV.
Right.
Ever.
Ever.
And we didn't even talk
Hooked
about
on
this. I
to it.
never see another elephant like come stick her hoof inside and see like how much longer we gotta go.
Exactly. And I think that's the other thing too is avoiding. This is a whole nother topic, but
Yeah.
avoiding vaginal exams, during labor and kind of feeling like you're on the clock, like I should have my baby by
At
this
all?
time.
Or like,
Technically, I don't know that you need any of them in labor. I mean, that's kind of my take on it, but the average woman gets 7.
During labor.
But it's
During
also
labor.
like when you think you're at 7 centimeters and then you get that pelvic exam and you find out you're only at 3, it's the sensation of unplugging the moon bounce and the whole thing just folds in on
Yeah.
itself. That's what happens
Like
to your
that
energy.
is, it's
Yeah.
And it could be in
Totally
an hour you will be
deflating.
Yeah.
7, but you don't know that, and you
Right.
you lose the mind game.
Bottom line is you'll know when it's time to start pushing because you'll feel a totally different sensation. And so, and I think at home, most of the time they really try, to minimize.
Oh yeah, I've been to home births with it. They don't do any.
Yeah.
I
And that would be, one of the things obviously is that you do have to check and make sure that the baby is in the right position. So you're not surprised. But again, if you've had an if the doctor's checked in the last couple weeks, you can be assured.
midwives are masters of palpation.
Yeah,
so they can
exactly.
because they don't have ultrasound, they can feel without doing it.
Yeah.
All right, guys, this has been incredibly fascinating. Thank you so much,
Thank
Dr. Hill, for
you.
being here. Where can we find you online?
I'm at www.laobgyns.com.
OBGYNs?
Yes.
Like plural OBGYN?
Plural.
Okay.
Yes.
LAOBGYNs.com.
Yes.
And your book is on Amazon. Again, it's called Your Pregnancy Your Way, Everything You Need to Know About Natural Pregnancy and Childbirth. And after speaking to you, it makes a whole lot of sense. The title really, if I ever come back into this world as a woman, I'm not having children unless you're my OBGYN. That's the thing. Megan, thank you so much for joining us.
Thank you for
I
having
hope
me.
that this is helpful.
super helpful.
And you get more, go home with more to think about. And just what I was telling you earlier today is like, if you're low risk, you have two very safe ways to have the baby at home or not at home. And so it shouldn't be so stressful for you. It's just which one's going to end up being better for you. Look at the pros and cons of both and make the choice that's right for you. And hopefully you'll come back afterwards and tell us how
Definitely.
it all ended up.
exactly.
Yeah.
We need the
Yeah.
finish to the story.
And,
Part 2. Yeah.
Yes. And Angelica, thank you as always for being here. Folks, tell your friends about the Informed Pregnancy Podcast so they can make informed choices and empowered decisions too. For more information on today's topic, together with our blog, documentaries, and other pregnancy and parenting resources, visit informedpregnancy.com.
Doctor, give me the news. I got a whole lot of questions for you.